Welcome everyone to today's webinar, Industry Pulse Check, How Providers and Payers See 2020 Healthcare Trends. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Now I'd like to introduce our speakers. Ferris Taylor is Executive Director of the Healthcare Executive Group, a national network of thought leaders focused on technology to grow, share, and reshape healthcare. Before this role, he served as COO and Chief Strategy Officer of Arches Health Plan. Taylor's career includes founding Pragmatic Healthcare Solutions, a healthcare strategy and market positioning firm, and serving as VP of Payer Market Strategy at Optum, VP Marketing and Planning at Partners Healthcare, and Head of Marketing Information Services at HPHC. David Gallegos, Senior Vice President of Consulting Services at Change Healthcare. David has more than 25 years of experience in health plans, hospitals, and large IDNs, with expertise in startup environments, turnaround operations, and post-merger integrations. David is responsible for leading Change Healthcare Consulting's efforts to deliver client engagements that optimize business operations, reduce costs, improve quality, and increase consumer choice, access, and satisfaction. He is also responsible for leading Change Healthcare's value-based healthcare and consumerism consulting practices. Michael Brusso is the founder and CEO of Insight Dynamo, a full-service insights research firm. Michael has more than 20 years of experience helping companies build and execute research programs. He has led research departments for several Fortune 50 organizations, including AIG and United Health Group. And he has managed research programs for clients such as Coca-Cola, Anheuser-Busch, and Philips Electronics. Michael has developed a toolbox of skills for launching new products and services, testing communications, and designing insight-generating programs. At this time, it is my pleasure to turn the floor over to David to begin today's webinar.
Well, thank you, Brian, and good afternoon, everyone. It's great to be here. Over the past 10 years, Change Healthcare and the Healthcare Executive Group have worked together to administer the Industry Pulse Research Survey. Each year, the Healthcare Executive Group at their annual forum vote on the industry trends most likely to impact healthcare in the upcoming year. This is a broad list that covers a number of topic areas, and while the list itself is newsworthy, 10 years ago we wanted to know more. We wanted to get a deeper understanding of the top industry trends, and we wanted to include perspectives of executives not at the conference. And so we launched the Industry Pulse Survey. Over the years, we've seen some trends come and some trends go. We've seen some trends rise and some fall. And this information has been very valuable to healthcare executives deciding where to place their bets in the upcoming year. This year was particularly a special year for many reasons. One, it was our 10th anniversary doing the Industry Pulse. Two, we had a record number of participants. We had 445. And three, we had broad participation with significant payer and provider executive level representation. Every year, the Industry Pulse covers a broad set of topics. And rather than try to cover them all in this webinar, we will focus on those we feel are most interesting and relevant to you. If you would like to dive deeper into these topics or review other areas that aren't discussed today, please feel free to download the report, which can be found on our website, thechangehealthcare.com, and we'll include the link at the end of the presentation. We're going to start with Michael telling us a little bit about the survey.
Thank you, David. Insight Dynamo was excited to partner with Change Healthcare and the HCEG this year on this year's Industry Pulse Survey. We fielded the online survey from October through December 2019 and recruited participants through email lists, links in social media, and LinkedIn, and are very happy with the respondents we gathered. Of those 445 respondents, nearly 1/4 were at the C-suite level in their organization, and 80% of all respondents came from director level above. As such, the 2020 Industry Pulse Survey represents the thoughts of decision makers across the healthcare landscape. Through our targeted recruiting efforts, we gathered responses from providers, payers, technology vendors, and nearly every other corner of the healthcare universe. The largest respondent group was from provider organizations at 30%, closely followed by another 20% from payer organizations. Ferris, when we look at past year's respondents, how does the 2020 Industry Pulse compare?
Well, thank you, Michael, and thank you, David, for partnership in producing Industry Pulse the last 10 years. HCEG was especially pleased to see the large number of participants. Having that large number allows us to do a lot more analysis as to differing viewpoints and where opportunities might exist in healthcare. And the growing participation of provider organizations, especially for this webinar with Becker's, allows us the opportunity to have more constructive discussions that will hopefully lead to real actions and to real solutions to the challenges in healthcare. As Brian said in the introduction, HCEG is a network of healthcare executives, thought leaders. We've been in existence for 32 years, working to improve and reshape healthcare. And each year our members discuss and debate critical issues, challenges, and opportunities across the healthcare landscape. And as David said, that leads up to a vote as to the next year's HCEG Top 10 priorities for the coming year. And what you see on the screen is the 2020 list. And we use that list to help focus and shape what we researched in Industry Pulse this year. Our members and partners have felt that the demand for change and the pace of innovation is accelerating as healthcare has moved to center stage in the national debate. As one payer commented in the survey, trying to disrupt ourselves from traditional healthcare, end quote. Therefore, it's not surprising that cost and transparency is at the top of the list. It's an underlying and growing challenge across all of healthcare in the United States, especially in comparison to other developing countries around the world. Healthcare accounts for 18% of GDP and more than $3.8 trillion in expenditures. As you see right below that, consumerism, prioritizing easy, convenient, timely, and effective interactions along the consumer's journey in healthcare, is difficult for many of us in healthcare for some reasons that we will discuss today. Transformation, delivery system transformation, value-based care transformation is desperately needed, with reports that up to 25% of our healthcare spend is waste and duplication. Other critical issues rounding out the top 10 include rapidly expanding data sources, enhanced analytics and technologies like AI and blockchain, interoperability, holistic individual and population health, security, health policy. With all of those, there are priorities and actions that need to be taken. And with that HCEG Top 10 overview, David, let's jump into Industry Pulse.
So as I mentioned previously, the Industry Pulse is really driven off of the top 10 list that Ferris put together. And this year, if there's one headline for the research that came out of this year's survey, I would say that payers and providers differ on the current state and the future state of healthcare, which I guess really isn't that surprising. One ex-boss once told me that where one stands is often dependent upon where one sits. So when you look at the data, I think it's obvious that providers and payers are in have different perspectives and different opinions about the future of healthcare. And in particular, payers seem more likely to have robust customer-centric strategies than providers. And as we see when we dive into the data even more in detail, providers are much more likely to have no customer-centric strategy at all. Payers and providers disagree on who's best positioned to provide cost and quality data to consumers, and payers are more likely to have mitigated to value-based reimbursement models, while providers are still relying on fee-for-service. While no research is perfect, and in many cases, surveys open up as many questions as they answer, but this year's survey, it's clear. There's no denying the dichotomy that exists between these two groups, and part of our challenge is going to be bringing both payers and providers together so we can solve some of these problems. Michael, let's dive into some of this data.
Thanks, David. We know that consumerism is having an increasing impact on our industry. In the 2020 Industry Pulse, we sought to measure the extent to which firms had adopted consumer-centric strategies. So we created a 4-point continuum and asked respondents to self-select where along that continuum their organizations fell. They could have no consumer-centric strategies at all, They could have nascent consumer-centric strategies, meaning they might have single-point solutions, but not an overriding organizational-wide approach. They could have intermediate consumer-centric strategies, meaning they might have a unifying philosophy, but they have not yet measured company-wide impact. Or they could have full consumer-centric strategies. That means a unified philosophy and it's yielding measurable results.
And on this continuum that Michael helped us create, it is clear that consumer healthcare or consumer-oriented healthcare is definitely changing, as Michael said. Let's look first at the C-suite payer executives and where they say they are at with respect to consumer centricity. No payers place themselves on the far left with no consumer strategy at all. 43% say they're still at that nascent stage of developing a consumer-centric program. Another 33% see them at an intermediate stage, but still struggling to identify those organizational-wide benefits, while nearly a quarter, 24%, say that their organization has a full consumer-centric strategy in place. And so when we break out the C-suite provider responses to the identical question, we see significant differences. Compared with payers who all indicated they have some formal consumer-centric strategy in place or in development, 14% of the providers say they have no formal consumer-centric strategy. Another 34% say they're still at that nascent stage of implementing a strategy, and of course that means that more than half of the provider respondents to Industry Pulse put themselves on the right side. 36% saying they have an intermediate level consumer strategy, and 18% claiming a full consumer-centric strategy. Other research that we looked at supports the importance for both payers and providers to be moving to the right on this continuum that we're showing here. 89% of the responders to the North Highland Beacon report indicated that creating a better customer experience for members and patients is the most essential strategic priority. And 95% of those responders said that it could have an extremely high impact on overall competitive advantage. So seeing where we're at in moving both payers and providers more to the right is critical for the success of healthcare. But highlighting the contrast between payers and providers is most striking on the far ends of this consumer-centric spectrum. 14% of the providers, as I said, say they have no consumer-centric strategy, whereas 100% of the C-suite payers say they have at least started to develop consumer-centric strategies. I'm sure there's many perspectives on why payers seem further along in supporting a better member experience. One might be that payers provide the lead in benefit design and in broad efforts in member acquisition, which requires a focus on consumer experience in healthcare. They also have had a basic customer service department for many years, while providers are just now beginning to look beyond their patient community to all consumers or to the population in their community on a broader basis. As one respondent said in the open comments in Industry Pulse, they're trying to get closer to the end of the healthcare value chain, members and patients, end quote. So, David, let's dig deeper into this consumer centricity issue.
Absolutely. And I do think, despite some of the numbers that we see here, I think it is important to note that a lot of providers do recognize the importance of developing and implementing a consumer-centric strategy. I was at the South Florida Hospital Association meeting earlier this month, and the consumer was the primary topic of conversation. Leaders from a number of regional health systems, Cleveland Clinic Florida, Broward Health, Baptist Memorial, et cetera, all recognize the changing trends in the customer expectations and their need to change to better serve their consumers. They use the term one-click expectations and recognize that customers now want service, quote unquote, right now. Amazon doesn't make them wait, so either should their healthcare provider. So as we look at the data, one of the things we see here in this particular slide is when you look at all responses from all participants, we see some level of agreement. When asked who is best positioned to provide cost and quality data to consumers overall, payers win the vote by 31%, responding that payers are better positioned to supply the information to consumers. Other choices also get significant votes. Providers get 22%, independent consortiums get 18%, and third-party technology platforms get 12%. Some write-in responses include health information networks, insurance agents, and government agencies. However, when asked who is better positioned to support the consumer on their healthcare journey, providers are overwhelmingly thought to be better positioned. In contrast, only 19% of respondents as payers. Some of the write-in responses include retailers and innovators, case managers, and friends and family. Now, when it gets interesting here is when you look at the payer versus provider perspective. When we dive deeper into the detail here, payers and providers have huge differences in opinion. While both payers and providers generally agree that providers are better positioned to support the consumer in their healthcare journey, there are significant differences on who is better positioned to provide cost and quality data. 73% of payers think payers are best positioned to provide cost and quality data to consumers, whereas 42% of providers think providers are better positioned. Personally, I'm not surprised by the payer perspective, given that they generally have a more 360-degree view of the member. Given the breadth of their claims data, payers know what services and drugs the member receives and how much they cost. They also have visibility across providers, so it's easier for payers to compare costs, utilization, and outcomes for patients, for similar conditions. Providers, on the other hand, usually only have data on services they provided to the patient and usually won't have comparison information about other providers that they're not affiliated with. So given this, I think it's very interesting that so many providers feel they are better positioned to provide holistic cost and quality information to members and patients. When we ask participants to rank a series of potential financial or billing improvements based on their potential to improve customer satisfaction, there was overwhelming agreement that fixing the basics would drive the most value. Now, granted, we offered them up these choices, and so there was limits to what they could select from, but even the write-ins pointed to that concept. Both payers and providers ranked plain EOBs and simplified invoicing as high impact areas at 70%. Both also ranked simplified benefit explanation and consolidated billing as high impact areas. Interestingly enough, while both thought elimination of surprise billing and clear identification of in and out of network providers were high impact, there was also significant differences in voting. Payers indicated elimination of surprise billing in greater numbers, while providers thought clear identification of in and out of network providers at a higher percentage. While there are also a number of write-in votes suggesting full transparency would be a high impact, and a few others to ultimately improve customer satisfaction.
And as with the financial billing improvements to impact customer satisfaction, we also asked survey participants to rank a series of factors for improving the consumer journey and impacts with respect to non-medical or non-clinical improvement options, as you see here. And those options included capturing medical encounters via audio or video, consumer access to provider notes, layman terminology and more medical information, non-clinical services like transportation, food, and housing, online scheduling, simplified prescription information, and a variety of virtual health options. When we analyze the frequency at which participants rank these options, these non-clinical factors, first, second, or third, the clear winner was online appointment scheduling, appearing at the top of the list for 73% of all responders, and a very, very closely aligned with 72% of payers and 69% of providers. Providers were the most likely to say that providing medical information in layman's terms would be among the most productive strategies at 62%. A little further down, 36% of the payers felt that simplified prescription information would improve consumer satisfaction, while only 23% of providers felt that would be a priority. A special note down in the corner, 24% of the providers expressed an interest in providing the ability for patients to capture physician encounters via audio or video. We might have expected providers to be a little more resistant to that idea for privacy and/or liability reasons, but they endorsed audio-video encounters as a strategy to improve customer satisfaction, even more than payers. I suspect video and audio from an encounter would also give the provider more confidence that their patients would understand and comply with the recommendations from the visit if the patient could refer back to the exchange of information after the visit. Other insights may come out of the Q&A today as you digest both the financial and non-clinical impacts on customer satisfaction. But let's move on. David, what did Industry Pulse tell us about value-based care?
Well, as with a lot of these questions, value-based healthcare is where we also saw a lot of differences in payer and provider responses. In particular, almost 90% of payer executives indicated they have alternative payment arrangements or full capitation versus only half of providers. Now, this may seem counterintuitive to some, as it takes both payer and provider to create alternative payment arrangements. But if you really think about it, I think it follows more like a Pareto principle. And while more research would need to be done to prove this out, in my experience, it's about 20% of the providers that have 80% of the value-based contracts. This is also consistent with the 2019 report by Catalyst for Payment Reform that said that 53% of all payments made by health plans to hospitals were tied to value-based models, and about 43% of outpatient primary care provider payments were tied to value-based. Payers generally, at least my experience, enter into value-based contracts with only those providers who are ready to take on the difficult task of managing populations and risk. And right now, that's probably a minority of providers. When asked why it's taken so long for value-based payments to take hold, payers are much more likely to cite IT infrastructure issues as the key barrier to implementing value-based healthcare arrangements, whereas providers see the unclear or conflicting performance measures as the biggest barrier. And again, this makes sense to me when you think of where both the payer and provider sit on the side of value-based care. Payers are more responsible for setting up their systems to handle the complex logic of value-based reimbursements at scale, whereas providers have the difficult task of trying to meet cost and quality standards of multiple payers. Interestingly enough, a number of write-in responses were more poignant. A couple cited, quote, not enough proven upside for providers to change habits or take on new tracking. And again, quote, rewards for accepting risk not commensurate with the expense and risk to implement value-based care. In the end, value-based healthcare models will only be sustainable when they're a win-win-win, when they work for provider, payer, and the patient.
Questions about the emergence and eventual adoption of value-based care have been a staple of the Industry Pulse for many years. Rather than ask how long until true value-based care were the norm, this year we decided we wanted to better measure current adoption of value-based care. So similar to the consumer-centricity questions, we created a continuum for value-based care. Respondents could place their organizations in one of 4 points. They could say they have no quality links, meaning that they're in regular fee-for-service arrangements. They could have fee-for-service with some limited link to quality, so some portion of their payments are based on quality or maybe efficiency of care. They could have migrated to alternative payment models linked to effective management of a population or an episode of care, and that could include ACOs or patient-centered medical homes. Or they could have migrated all the way to full capitation where clinicians and organizations are paid for care of a beneficiary for a period of time, like per month or per year.
And as we saw with the consumer-centric measurement along this continuum, there are also differences in where payers and providers view themselves on the value-based care maturity continuum. A significant majority, as David said just a few minutes ago, 67% of the C-suite payers say they have moved to alternative payment models designed to emphasize value over volume of care. And another 20% say they have moved to the full capitation part of this continuum. Zero payers say they are reimbursing fee-for-service with no quality links, but 13%, as you see here, say they're still covering fee-for-service with some consideration on quality. As we look at C-suite providers, they have a much more modest assessment of their progress towards value-based care. 13% of the C-suite providers say they are still billing on a fee-for-service basis with no links to quality, and 38% of C-suite providers place themselves at the early stage of fee-for-service linked to quality in some way. Although 50% say they're working with alternative payment models, it is striking that no providers say they are doing business based on full capitation versus the 20% of C-suite payers at full capitation that we saw on the previous slide. So the stark differences between the payers and providers is more obvious if you look just to the right or to the left of the center line on the value-based care continuum. As David pointed out, nearly 90% of the C-suite payers, the 67% plus the 20%, say they are over the hump to the right of this transition to value-based care, while 51% of the C-suite providers say they're still on the left-hand side. The basis on which payers reimburse should be the same as the basis on which providers are paid. It could be that payers have their, as David pointed out, have their highest volume providers in value-based care contracts and therefore characterize their business as primarily value-based. Providers may also be more conservative in assessing themselves as still operating predominantly in the fee-for-service model, even if they participate in a few value-based contracts with the major payers in each of their markets. Providers may also purposefully not want to change the care or the way they approach care based on which payer contract might be involved. Other research I've seen has shown that 85% of physicians say that access to quality and performance measures specific to their patients is key to achieving value-based care. So there is significant agreement as to the direction we need to be going on this continuum, further and further to the right. And to better help us understand what's holding back this transition to value-based care, we ask specifically this year, what are the barriers to this transformation? Payers and providers had different priorities as to the biggest barriers or culprits that they were facing. 29% of providers said that it was unclear or conflicting performance measures, while a quarter of the payers pointed to a lack of or limited IT infrastructure. Providers were also more likely to point the finger at regulatory changes or political uncertainty, which 18% saw as a problem, compared with only 4% of payers seeing that particular issue as a problem. One provider commented, and I quote, "I can only see, let me get this right, I only see continued and added hoops through which to jump," close quote. That could be because of a growing percentage of the provider business coming from government programs like Medicare and Medicaid, where regulations have a significant and in many times an uncertain impact on their business. For payers, right behind IT infrastructure challenges, 21% of the payers had financial risk concerns near the top of the list, compared with only 12% of providers. So where payers perceive themselves further to the right on the value-based continuum, we ask the question, what can payers do to more effectively support providers in value-based care? And over a third of the providers, 36%, see standardizing quality and outcomes data, especially across the many payers each of them have contracts with, as a key to the transition. This compares with only a fifth of the payers at 19%, seeing that as a help. The greatest potential payers see in working with providers is back to developing shared risk management programs, a top choice for 22% of the payers, but only 13% of the providers. Reflecting on the concern about IT infrastructure shown on the previous slide, 70% of the payers see developing APIs to improve interoperability as among the keys to value-based care, while only 7% of the providers thought that was important. Bottom line, there is much to be done in this transition to value-based care, and payers and providers view some of those barriers very differently. And as Michael had pointed out, value-based transformation has been on the HCEG top 10 list for over 10 years. And in the past, we've asked how long it would be until the majority of healthcare was value-based, and consistently the answer was it was out 3 to 5 years. And that 3 to 5 years is kicked forward over the last 10 years. Looking at the question of how health plans can effectively support providers, we can see we've made some progress. At the top, standardizing quality and outcomes data compared to last year is still the most popular performance improvement measurement, cited by 26% this year, a number very similar to 28% last year. We did see a drop in co-developing payer-provider risk management programs at 18%, compared with 23% last year. And interest in sharing outcome data rated 13%, up from 8% last year. Both those changes year over year align well with the earlier priorities that we saw in the Industry Pulse results. And I think for the audience today, it's good news for providers. Everybody's moving in kind of the right direction. A telling comment from a provider respondent was as follows, quote, "Moving away from payer models where value equates to cost and developing models that rely heavily on value measures for better outcomes. In effect, the carrot, not the stick," close quote. And a payer shared, all healthcare organizations need to realize the necessity to work collaboratively to find a solution that provides quality, efficient healthcare for all. So, that's value-based care, but another dimension of value-based care cuts across several of the challenges that is in front of both payers and providers. And that is starting to look beyond the narrow definition of healthcare as an individual's medical condition and looking at the broader barriers to health, what more commonly is called the social determinants of health. And David, you might want to talk to some of the results there in Industry Pulse.
Absolutely. And as I mentioned, I was at the Florida Hospital Association meeting a couple of weeks ago, and at that meeting, there was a lot of discussion about the topic of personalization of health and the need to collect better data to drive more customized treatment options. Our survey shows that payers and providers both reported collecting a wide variety of this social determinant of health data, from tobacco and alcohol use to employment and housing. And from the responses we received, providers were more likely to capture substance abuse information, whereas payers were more likely to capture income data. A couple of years ago, the health system that I go to, Cleveland Clinic, Florida, went all in on this information. They have a pre-check process where I can log online even prior to my visit and fill out a whole set of questionnaire information. And then they have another short questionnaire when I get into the office. These questions include things like, do I have enough food? Do I have secure housing? They even ask if I feel safe at home. That said, I've been filling out these questionnaires for a couple of years now, and I haven't seen them integrated into my visit. Never has my physician or nurse practitioner referenced this information in our conversations. So just because the provider has the data doesn't mean they use it. So, I see this as a work in progress. Collecting it is clearly a step in the right direction, but leveraging it as part of the integrated whole person care treatment approach, I think is really the next step. So, you know, we really have been talking about social determinants of health for more than 30 years. It's kind of amazing. When I started in healthcare in 1992, you know, the big conversation at the time was integrating behavioral and primary care. Here we are, you know, almost 30 years later, and we're still having conversations about integrating primary and behavioral health. You know, it's good, though, that there's finally real recognition that what happens outside the doctor's office has more of an impact on health than medical treatment does. One study that I read recently said that social, economic, and behavioral factors were 7 times more influential than the quality of care. So, you know, again, this was a big topic at the South Florida Hospital Association meeting I attended. Many at the conference mentioned, as our survey respondents did, that coordinating with community-based organizations is key to really, you know, making sure that patients are healthy and stay healthy outside the office. And as you can see from the chart here, 30% said they are providing some level of direct support to members and patients based on social determinants of health. Another 14% said that they're coordinating with community-based organizations and resources. Addressing an individual's biopsychosocial needs is something personally I'm very passionate about. I started my career, as I mentioned, 30 years ago about working for a managed Medicaid plan, and I see firsthand the difference healthcare organizations can make in people's lives. Individuals that can't manage their chronic conditions, that can't secure housing or don't get enough to eat will have difficulty staying out of the hospital, not to mention getting a job and lifting themselves out of poverty. It is nice to see that only 3% of healthcare organizations are not integrating social determinants into these programs, and this is down from 6% the year before. I'm looking forward to when that number is 0. When asked how effective you feel AI and machine learning have in impacting certain areas, both payers and providers cite improving health outcomes. Providers also cite improvements in health efficiency and cost reduction as some of the benefits, whereas payers were less likely to cite those. Clearly, we're just getting started with AI and machine learning. According to the FDA, artificial intelligence and machine learning technologies will have the potential to transform healthcare by deriving new and important insights from the vast amount of data generated in the delivery of healthcare every day. And I totally agree with them. A recent Dell EMC study I read said that healthcare data has grown over 800% since 2016. And according to an IBM report, they expect that healthcare data will now double every 73 days. As we get better at harnessing this big data, I expect the effectiveness rate to improve over time. Given the fragmented healthcare environment we work within, interoperability is going to be crucial for all of us in order for us to share data and coordinate care. When asked what is most likely to drive interoperability across the healthcare system, both payers and providers cite regulatory changes and technology. I'm not surprised by this, but I am disappointed to some extent. I'm disappointed that we still need the government to force us to work more collaboratively, whereas corporations in other industries, retail, transportation, etc., work together to develop standards that connect their supply chains. I also think that it's interesting that the C-suite respondents cited that the main thing that will drive interoperability is the consumer. And I wonder, and when they responded to this, what consumer they were thinking of. Were they thinking the purchaser of the healthcare premium, which is, you know, primarily employers and the government, or are they thinking individual patients? Because I think if we're waiting for the individual patients to drive interoperability, we'll be waiting for a long time. And that's primarily because the patients, unlike other industries, still doesn't have the same power of the consumer that you have in, again, retail and travel, et cetera. One of the write-in comments that I think sums it up best as it relates to interoperability and the movement toward really connecting our delivery system cites that it's not just one thing that's going to solve all this. It's going to be, quote, a collaboration of quality initiatives evidence-based outcomes, and financial rewards to develop a win-win strategy for all stakeholders. So ultimately, I think that's really what's going to make interoperability happen.
So across all of the topics, David, you've covered, and even those that we talked about before, a final highlight to start this discussion with all of you today is that privacy and security has significant implications. It impacts the consumer's trust in healthcare. Concerns about privacy and security constrain advances in data liquidity and interoperability that David has discussed. It impacts more robust AI and other technologies, as they will be constrained if we can't assure that the data and the systems are private and secure. For the most part, when we ask this question in Industry Pulse, participants in the survey agreed on the top 3 or 4 reasons why cybersecurity breaches are a significant issue in healthcare. The responders first said the sophistication of attacks are increasing faster than prevention capabilities at 82% across all responders. And this is a similar concern as I look beyond healthcare at all other industries, and consistent with last year's response that we had to the cybersecurity question in Industry Pulse. Attackers can probe and experiment endlessly and only need to be right once to find a vulnerability in our healthcare systems. The defenders of information systems need to be right all the time as they work to detect, block, and prevent attacks. Other big challenges include accounting for human factors in information security at 66%, and the cost of achieving an ironclad defense of information assets of 56%. As a payer said in the survey, quote, prioritizing the business initiatives, including cybersecurity, to align with available resources, close quote, is a serious challenge. Along that line, one result that stood out this year was down here in the lower right-hand corner again, that 24% of the C-suite responders pointed to an insufficient recognition of cybersecurity as a priority at the executive and board level. David, Michael, and I might have expected C-suite to point the finger somewhere else. But the fact that they were more likely to blame themselves than all respondents were at only 19% is very interesting. Needless to say, this has to change with respect to cybersecurity. Healthcare remains one of the most highly targeted industries for cyber attacks, accounting in one report that I saw for 41% of all breaches across all industries. IBM and Poneman put the cost of a healthcare breach at the highest of any industry, the cost at $429 per record. And healthcare has been the highest of any industry for the last 9 straight years in their research. Maybe the C-suite is right in saying that cybersecurity needs to be a higher priority for healthcare. But obviously, with the time that we have, we'll defer a more detailed discussion of cybersecurity solutions for another day. We wanted to be sure to leave time for the many questions that we see coming in. So, Brian, and if you have any summary comments, or you can take us directly to the questions that you see coming across the screen. We appreciate your time today.
Yeah, thank you so much, Ferris, David, and Michael, for that insightful presentation. And we will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to get through as many questions as we can. And we've had a bunch of great questions come in today, as Ferris mentioned. The first one we'll go with is this attendee is looking for a little bit more clarification around the definition of consumer. So the attendee is wondering, is a consumer those who consume your services, or is it the population in your service area, whether or not they are using your services? David, perhaps you can kick us off here, and then Ferris or Michael, if you want to pitch in too on this one, that'd be great.
So I think, it's interesting. It's a great question. I think, the definition of consumer is changing. When you look at who ultimately is paying for healthcare, 20 years ago, it was employers and the government primarily. That has shifted dramatically as the patient is paying more out of pocket for their services. And so I think the whole concept of who is the consumer and who ultimately is driving, the healthcare dollar. And in reality, it is the individual patient or member that is in a sense, the fastest growing payer in our industry in terms of their percentage of out of pocket. So that being said, the consumer still, I think, is weak compared to other industries. When I say consumer, I mean the individual patient, because at the end of the day, they're not paying still the bulk of the premium. But this is going to continue to evolve, and clearly healthcare organizations recognize the need to pay more attention to the individual and to their experience.
And I'd add to
Thanks,
that,
David.
And thanks for the question. We certainly struggled with when we were putting Industry Pulse together, what word we use, and clearly for the provider, the first line of focus, as David said, is on the patient. But for the health plan, it's a much broader definition there. I've attended the last 3 or 4 years AHIP's Consumer and Digital Health Forum, and have, as the person that asked the question, have struggled with how do we get the consumer to the center of the healthcare proposition, and by that it's the member or the patient into the center of that. As we launched Arch's Health Plan here in the state of Utah, we went out and talked with providers. And it was terrific talking with providers about how great they were taking care of their patients. But from a health plan perspective, those providers were only seeing 30 or 40% of our members, which we would have defined as a consumer. And when you ask the question of the provider, well, what are you doing for those that aren't necessarily coming to visit you every few months or every year? There was quite a loss as to how they would look at that broader community, the more broad definition of consumer. Do they have health coaches in their offices? Are they helping with nutrition, healthy eating? How are they addressing those social determinants of health that David talked about? And I think that for all of us, broadening our definition of the consumer, as David said, away from just the employer or the government that pays the premium to the population that we're interacting with and responsible for in terms of their overall health and well-being is a critical conversation that needs to take place.
Michael, you want to add anything?
Yeah, I was just going to clarify that when we asked the question within the survey surrounding consumerism, it was always clarified that we were primarily talking about members or patients. So when they were answering questions about driving consumer satisfaction, that was the context that respondents were using to answer those questions.
Okay, great. Thank you. Thank you for that. Brian, any others?
Yeah, I definitely appreciate all the clarification there. And this next question here is a little bit of a longer one, so I'm going to read through it, and then if I need to go back, just let me know. But I'm just going to open it up to all of you. So the attendee asks, providers can better strategize if we help them to have deeper pockets. An advantage of our payer community, we talk about partnership. For a true win-win, then we need to ensure that both sides are winning. Not a competition between payers and providers, but a genuine partnership. Can you speak to this, incentives and promoting collaboration?
I guess I'll just start. I mean, I do think that, it has been historically, and I think it still is in many cases, that many payers and providers still believe that they are on opposing sides. And often this is a, kind of a zero-sum game that often gets played out when they're having conversations with each other. But I do think that payers and providers really need to look at themselves as a partner, that they are really the opposite sides of the same coin. And as soon as payers and providers start working together on the same goals and objectives, then I can see us really have some serious movement toward the objectives we talked about a lot today. I'm a big believer in value-based care. I believe in many respects it's the holy grail of all of our healthcare woes, and I know that's simplified it to an extreme event. But I think once we have value-based payment arrangements in place and you have alignment of incentives, then things like interoperability, care coordination, open standards, all these things become a benefit to all the players. And then everybody, hopefully will get in line behind working together to solve some of these problems. Ferris, you want to add into that? Any comments?
We could probably talk for an hour about that question. I think it's at the heart of many of the challenges in healthcare. Both sides winning, all sides winning. In some ways, I think every single one of us in this siloed industry that we call healthcare, because it isn't really a system yet, we're not working together. We're very siloed, but in some ways we've taken health out or care out of the system and are driven by many conflicting incentives and motives and like that. That said, if we don't change, I'm not sure there's win-win solutions for the payers, the providers, or the consumers, including the employers. Those of you that know me hear often me going back to a quote from Michael Crichton's book, Lost World. And the quote is essentially, extinction is the inevitable result of one of two things: too much change or not enough change. And I think what I saw in Industry Pulse this year and the size of the research or the respondent that we had where we could start breaking out some of these details, every single one of us in healthcare need to look in the mirror and decide what changes need to take place. And in that win-win that was mentioned in the question, Brian, I would also want to have the consumer and the consumer, the patient, the members' outcomes be part of that win. I look around the world and our members, our patients in the U.S. are not winning right now. We have very poor outcome results, and that's part of the winning proposition that needs to be factored in as well.
Thank you, gentlemen. The next question I'll take here is it relates to social determinants of health. So the attendee asks, actions related to social determinants of health. Do you have provider versus payer data?
I'm not sure if I the data we have is pretty much what we shared. Michael, can you speak to anything else that we may have other than what we already shared?
Yeah, actually we do have a little bit of data, and that's beyond what was presented here. I believe the respondent or the questioner is asking, related to that year-over-year question, we were asking what organizations are doing with social determinants of health. We do not have that data over time broken out by payer versus provider, but this year, since we had enough responses, we do have some directional differences that show up with them. And rather than getting into a discussion where I talk about the exact percentages of differences, I can say that there generally seem to be areas where payers are more likely combining social determinant data sets. So they're combining it with other sources like financial or census data and using that probably to drive AI, to drive some of their decision-making software. Payers are much more likely to be providing transportation assistance than are providers. Providers, on the other hand, see themselves as more likely providing financial services to at-risk members or patients. That may be in the form of them waiving fees, waiving copays, doing whatever they can to assist individuals. So those are some of the general differences that we see with these two populations.
Thank you for diving a little deeper on that data, Michael. Appreciate that. And with just a few minutes left, we might have time for a couple more questions. So the next one I'll take here is the attendee asks, what are employers' trends and how are they similar or different from the consumer trends that were presented? Most consumers still select plans based on the choices provided by employers.
That is exactly. Go ahead, Ferris.
Go ahead, Dave. You know, the employers seem, especially here in the last few years, seem to be on the leading edge of the trends, the piloting. Of course, we have Amazon and Berkshire Hathaway and JP Morgan combining 1 million employees now, looking at what they can do to impact the cost curve in healthcare. I do see that there's a lot more creativity. When I was chief operating officer of a health plan, our employer discussions were always pushing the envelope as to what we could do to better create better benefit designs. But the person asking the question is absolutely correct. If the employer only offers one health plan, the employee only has one choice. We are seeing trends and regulatory trends that would open that up more and more to a broader set of options for each employee. At least that'd be my perspective, David. What about you?
I agree, and you know, in many respects, until the consumer ultimately has more choice in terms of who they choose and why they choose them, we're really not going to live in a customer-centric world. You know, so I'm a big fan of a consumer choice, but that means really letting them have a broader opportunity to choose from the multitude of payers that are out there in the industry, not just the one or maybe two that the employer provides. So this is one of the challenges we'll face from a policy perspective over the next decade or two, probably.
Appreciate that. And we just got about 3 minutes left here, a couple minutes left. So this will be the last question. And I would also invite Ferris, David, Michael, any additional closing comments you'd like to make, you can tack those on here as well. So the attendee asks, I see number 1 in the top 10 is related to costs. Not seeing a lot of content in your slides on addressing lowering. If payer and providers use value-based care as an integrated model, they can work together to reduce the cost of care to the consumers. The attendee is just asking for you to talk a bit more about this topic. Would anyone like to weigh in?
Yeah, I mean, I think, I'm sorry, we're all passionate about this topic. Obviously, we're all going to jump in. But, you know, clearly the cost of healthcare, the rising cost of healthcare is unsustainable. Now, we've been saying that since the 60s when it was 12% of GDP. So it's unbelievable to think that it's 18% and soon to be 20% and rising. At some point, we're really going to have to address this. And as Ferris mentioned, if we don't, in a sense, somebody else will, because you know we really need to change. And I do believe that value-based healthcare is the path that is most likely to help facilitate this. You know. At least in a free market way, without the government kind of stepping in and putting price controls or something else in there. I mean, we really need to align incentives to drive out waste, to drive out you know, inappropriate treatment decisions, to create more evidence-based approaches to medicine. And we also need to look at ways, personally, I believe, ways of leveraging different licensures within the medical, I guess, population, within the, you know, the nurses and doctors, et cetera, so that they're practicing at the highest level possible. So I think if we were to leverage some of the professionals we have in the system to do different things, we might be able to see some cost savings. But we won't do that unless there are aligned incentives that really provide a mechanism for the delivery systems to really redesign how they provide healthcare and ultimately enable them to make money while also serving their patients.
And I know we're out of time. We can pick that conversation up one-on-one or via follow-up discussions. If you look at the HCEG top 10 over the last 10 or 15 years, we continue to get deeper and deeper into the costs. Last year, the research went deeper into pharmacy costs, and of course we are all sensitive to what's happened with the opioid crisis and the things that we've created there. Surprise billing right now is a critical issue. So go to hceg.org and look at some of the historical changes in the top 10, and you've seen consistently this issue move to the top of the list. It's a topic in and of itself, Brian. So thanks to the listener for asking the question. It's the heart of what we're dealing with right now.
And that is all the time we have for today. I want to thank the attendees we had some great questions here, for all that great engagement. I want to thank again Ferris, David, and Michael for their excellent presentation, and Change Healthcare for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.